I'm very happy to be able to talk with you all today. I just wish that I could do it in person. It's just two or three of you at a time, and we could sit down and chat and talk about all of your experiences. I know that combined, all of you have a lot more experience out in the public with all these individuals that are struggling than I ever will in my whole career. And as a whole, our knowledge is great as long as we can share that. And I want to share some of my experiences and some of the things that uh, the research is pointing to. Um, as you'll, as we read some quotes in the slideshow, you'll notice hot links underneath them. I'm not going to cite every study because in medical presentations that becomes very long and boring. But when you guys get the PowerPoint, you can click on those and it'll take you to the original article um, and or research study there. Let me I'm going to skip over the learning objectives here because we're going to cover them all, but you'll be able to see those uh, when you have the PowerPoint. I'm going to start with the current state of the epidemic that we're in. In 2021, there were 446 opioid overdose deaths in Utah, which accounted for 67% of all drug overdose deaths in the state. Drug poisoning deaths are a preventable public health problem. They are the leading cause of injury death in Utah, outpacing deaths due to firearms, falls, and motor vehicle crashes. So they're the number one cause of death between 15 years old and 45 years old in the nation right now. 11 Utahns die each week from drug overdose, 7 of which are the result of opioids, 4 due to prescription opioids, and 2 due to fentanyl specifically. Utah is particularly affected by prescription opioids, which are responsible for 38% of the unintentional and undetermined drug poisoning deaths in the state, although illicit opioids, specifically fentanyl, are increasing more rapidly. Now, this is increasing so rapidly that these statistics, even though they're only a couple years old, are already wrong. Fentanyl is skyrocketing, and so it's we don't have. I have some statistics in here from 2023, but uh, just know that they're all higher than it says now, or than it says in these quotes here. Opioids, mainly synthetic opioids other than methadone, are currently the main driver of drug overdose deaths. Nearly 88% of opioid involved overdose deaths involved synthetic opioids. Opioids were involved in 80,411 overdose deaths in 2021, 75.4% of all drug overdose deaths. In 2023, there were approximately 110,000 overdose deaths in the United States and 691 in Utah, or 1.9 per day. The substances commonly involved in overdoses, however, have changed. From 2019 to 2020, the number of fentanyl-involved overdose deaths increased 128%. Note that's in 1 year, and that was during the pandemic, so now we're significantly more than that. It has continued to increase. The number of deaths involving fentanyl surpassed that of all opioid prescriptions in 2022. Additionally, there were more deaths involving fentanyl than heroin in both 2021 and 2022. In a single day count in March of 2019, 29,186 people in Utah were enrolled in substance use treatment, an increase from 12,496 people in 2015. In a single day count in March of 2019, 5,725 people in Utah were receiving buprenorphine as part of their substance use treatment, an increase from 790 people in 2015. This is from the DSM-5 definition for addiction. It's actually opioid use disorder. I'm not going to go over all that right now, but it's important to note that use of opioids has to be accompanied by disruption in the functioning of a person's life, as well as in inappropriate behavior to be addiction. And that's important to know for future use of opioids. When people reuse during treatment, it's different than relapsing. Relapsing means also taking upon these behaviors that are negative behaviors that are addiction, as opposed to reusing one weekend and then coming back to their provider and saying, hey, I had a bad weekend and I reused, but they didn't lose their job. They didn't lie to anyone. They didn't, so they aren't necessarily relapsing, which means addiction, again, or addictive behaviors. They reused. I was going to try to summarize the complex neurological adaptations. Oops, looks like I edited that incorrectly there. You can't see the bottom line there. But from opioids, it is complex. Just to re, to reinforce how powerful opioids are, um, the the adult brain generally is not very plastic, and plastic means that changes that can take place within the brain, um, that usually takes hard work and many months to change automatic responses and pathways within the brain. And that's what therapists, that's what you guys do all the time. You're working with people to make these changes, and even though they might know the right thing to do, it takes a long time to actually change the brain. However, with certain things, can cause very rapid and long lasting changes. Opioids, especially fentanyl, does this, and trauma can also do this. So these changes that take place in the brain in this diagram here, and there is a link to that, we can start to notice blood flow changes in the brain after even 1 or 2 uses of fentanyl. But then those persist, even if somebody goes into rehab, those persist for many months, more like a year and a half afterwards to come back. So something that could take just a month or two to create these changes in the brain can then take a couple years to actually reverse it, if the person's doing hard work, doing their part. Um, like I mentioned, trauma can also do this. And this is something that in therapy, you guys run into a lot. You guys have seen where a trauma on one day can then have years of effect afterwards. Opioids are like that. This has major implications for our patients and thus for our practitioners also. We need to understand that while we can detox quickly and change our mood and outlook during inpatient rehab lasting 1 to 3 months, the automatic responses of our brain take 18 plus months of effort to change back to something resembling normal. That is not well understood in the public, and it's not well understood in the rehab industry, but that's part of the reason why we see so much relapse after these treatments. Patients feel like they're doing good, but then a stressor hits them, maybe another trauma or problems at work, or their boyfriend or girlfriend threatens to leave them, something like that. And the brain has not gotten away from that automatic response to seek comfort from opioids and turns back to that right away. And this might be a year later. And we'll talk about this more in the presentation later, but that's why duration of treatment is so important. It doesn't matter how good a person's feeling right now, a very small percentage, 5%, 10%, will have the strength and the organization of thought and high functioning to be able to resist those cravings when they come, if enough time has not gone by, like a year and a half of treatment or 2 years of treatment. So I'm going fairly quickly through the first few slides here because then I hope to have some discussion after that. Why do therapists and doctors care about treating opioid addiction? With the epidemic, we're hearing mostly about deaths. But besides being the leading cause of death under 45 years old, opioid addiction causes people to choose to give up precious life experiences in exchange for temporary relief from suffering and for a temporary and false sense of safety. So what precious things are our patients giving up? They're giving up intimate relationships with family and friends. They're exchanging that for distrust, objectifying selfishness, which is hurting those relationships. They give up responsible parenting. They will be found sleeping next to a crying baby, and their spouse will not like that, and it's not good for their parenting or for the baby. And they're giving up developing discipline within a job or a career or a hobby pursuit. They're giving up maintaining an organized way of living in their home, their goals, their fitness, their financial stability. So what are they getting relief from? We've had decades, since the 1950s until now, thinking that opioids and those kind of and other hard drugs were basically partying. Like the person felt good, they liked it, they wanted to get out there and just have a high. In reality, we find that very quickly that goes away. Very quickly. The reward for taking the drugs goes away. The craving becomes a craving for relief, and the relief from the effects of trauma. So big T and little t. I know that's a those are kind of catchwords that are out there, but big T being the trauma that everyone in society would have always agreed on was trauma. That's like getting beat up in an alleyway, traumatized that way, or seeing somebody die in front of you in war. But the little T of feeling helpless, of feeling abandoned as a child, of other things like that, bring on terrible feelings of self-loathing, self-hatred, fear, anger, anxiety, loss, boredom, sadness, overwhelm, poor concentration, flashbacks. It is amazing how powerful these emotional pains are in driving us to want to get away from them, much more powerful than the attraction of a high or feeling high. And that ends up being the difficult part of getting over drug addictions or use disorders, is that a year later, you can have something very bad or uncomfortable in your life that brings back these bad emotions. And your brain thinks that in order to survive this dangerous situation, you need this ingredient, which is opioid. It's the same as if you've been in the desert for days and days with no water, and someone says, nope, you can't drink this water that we have here. And your brain will think about that water 24/7. And we know that 0 people can resist that without maybe 5 or 10% can. That's what the statistics show. 90% can't resist that. What we hope to do with our treatment is give the person an alternative. We're like, well, you can't have that water because it's poison, but you can have this nice cold Gatorade. And they're like, oh, well, that will substitute. I can handle that. I can take that Gatorade, satiate my thirst, and I can forget about the water for a while. Anyways, powerful thing. Dependence on a substance often results in a moral injury early on, like starting the drug. We commit a moral injury. And a moral injury is when we do something that goes against our own personal beliefs of what's right and wrong. And it causes one of the most insidious types of trauma, the trauma where we are both the victim and the violator. So we were both we assaulted ourselves, essentially. We assaulted our brain's sense of right and wrong. That's a very hard thing to get over and drives a lot of people to use over and over again. The drive to escape from these emotions is very powerful and subconscious. One thing I wanted to go into just for a moment, some more recent studies looking at dopamine, which is kind of the reward hormone, found that early on, like the first few times that we use opioids, that we get a huge release of dopamine. In other words, a huge reward when we take those first few uses. It feels really good, and it feels good to escape. But very quickly, those reward dopamine releases become smaller and smaller and smaller. And our craving, the reward for seeking goes up. And so what happens is that the desire to seek it gets stronger and stronger and stronger until when we start the action of actually going to buy the drugs, to get into the habit of taking them, we get huge dopamine release. But when we actually take the drug, we don't anymore. Isn't that ironic? You stop getting any reward, yet for some reason it seems like something we need more than anything else in the world to go obtain that. But then it doesn't even give us the reward after. And that's an irony of addiction. Feel free to break in with any questions you have at any time. I'm at any point I can answer questions, but we'll have plenty of time to have a discussion at the end also, if it seems more reasonable to wait and hear me out. So just break in and let me know if there are any questions at the end of each slide. So with historical treatment methods, the first sanatoriums and they call them houses that were used to help people get off alcohol and other drugs started in the late 1860s. In the early 1900s, we had the first morphine treatment programs where people coming back from World War I could get morphine to help satiate their cravings, so they also wouldn't do illegal things. And this is pretty similar to our methadone clinics now. They actually ended in the mid or about 1925 or so due to legal issues. But those were kind of the first attempts at this. The American Medical Association, well, I think Alcoholics Anonymous started in 1935, so that was also very early on there. The American Medical Association emphasized drug addiction as a chronic disease in the late 1960s and early 1970s, giving more legitimacy to treatment and causing medical insurance companies to begin paying for treatment. The vast bulk of treatment has fallen to therapeutic communities. That's the definition we give to groups like Alcoholics Anonymous, Narcotics Anonymous, lots of other groups. And inpatient drug addiction rehabilitation programs. That's kind of what we think of nowadays as all the drug rehabs. And short-term inpatient detox units at behavioral hospitals. And that's like at Aspen Grove. We have a wing of our hospital where we work with detox there. These programs vary widely in the therapeutic modalities used and in their overall philosophies. Despite recognition as a chronic disease, the medical establishment has not shown much motivation to integrate treatment of addiction into the mainstream of care. In my personal graduating class of 150 doctors, not one was interested in addiction as part of their practice. Zero. Due to this apathy, not much funding was available or has been available for research studies. A search of all the studies carried out on addiction treatment reveals tiny, underfunded studies scattered over the last 30 years. When compared to any other chronic disease with a major death toll and morbidity, addiction has a tiny fraction of the research. If you even tried to start reading the research for heart disease or kidney disease, you would have an entire library full. We're talking thousands of studies, hundreds of thousands of pages. When you look at like buprenorphine and that, this is a bit of them right here. Here's about 40 studies that I read in preparation for this, but these really, there's maybe about 100 significant studies, but if you actually look at the number of participants, a lot of these studies have 7 people in them or 100 people in them, but they don't have 100,000 in multiple countries like they do for heart disease and other cancers and other hormone issues and things like that. So really tiny bit of study, and that's sad, but it's also exciting for me as a doctor because I get to come into a vacuum and really be part of the growth of this knowledge and figuring this problem out. The chronic disease model and why it's necessary. There are approximately 1,400 general internists and family physicians in Utah. All of them treat diabetes, heart disease, hyperlipidemia, hypertension, asthma, depression, PTSD, eczema, traumatic brain injury, obesity, etc. The primary objective of treating these diseases is to minimize the effects on the patient's health and functioning. Ideally, the patient can be kept stable enough to not need the emergency department, the intensive care unit, or long-term rehabilitation. These goals are achieved through long-term, consistent follow-up, monitoring, and adjusting treatment as needed. Currently, only a handful of primary care providers in Utah, maybe 20 to 40 from the research I could do, and I've done quite a bit of research over the last 5 years, treat opioid use disorder as they would other chronic diseases. The vast majority refuse to treat it at all. The funny thing is I know a lot of doctors, and if you look at the SAMHSA buprenorphine prescribing database, which is on the web, online, almost every doctor is on there. There's hundreds in Utah. And I personally, of all the ones where I recognize their name, none of them are prescribing it. So it's not really very available. I talk to patients who have to call 20 names down the list to find one, and they're several months out. We have that problem when we're discharging patients from the behavioral hospital all the time. We rely on inpatient detox, followed by inpatient rehab for 30 to 90 days, but almost never care from a physician before or after this. Imagine how poorly diabetics would do if you just had to wait until they went into a diabetic coma and went to the ER, and then went to the ICU to be stabilized, and they got insulin and other meds while they were there, And then they went to an inpatient rehab afterwards and were rehabilitated from their brain injury they got because they weren't breathing well during their coma, etc. And after 90 days, they were left back out again. And they got to meet with a motivational group of other diabetics that had no care either. I mean, that's what Alcoholics Anonymous gives very good support to each other. But that would be like a diabetic going to a diabetic support group and still having no expert follow-up, right? Because just expert help. Very few diabetics would be successful in managing their blood glucose if we treated them this way. The same if somebody had acute heart failure and went to the hospital or had to have open heart surgery, very few of them would survive long if they were discharged home from the hospital without long-term follow-up. So integrating opioid use disorder treatment into a primary care practice can be challenging. I'll talk about this in a bit. Any questions yet?
Yeah, it looks like we do have a question in the chat. Katie's asking, is the dopamine response getting smaller to opioids also a similar response an individual experiences in social media or gaming?
Yeah, so we have found a similar uh, addiction type response to those to gaming, gambling, pornography, social media, the same type of thing. And it is an incredible irony because the desire and the craving for that becomes almost out of control, super high dopamine levels if we are in the pursuit of it. But once we get it, we don't get that reward anymore. Yeah, so it is the same. It's opioids are much more powerful, and fentanyl is on a different level, and that's a big problem we're seeing. So fentanyl, take every other opioid we've ever had. Well, it's 50 times more potent per milligram than heroin. It's 100 times more potent than morphine per milligram. So it's kind of in a different world, but it affects the nerves and the neural tissue weeks after detox is over. So it's a little bit, we don't understand it, but it's worse. That's a good question. Yeah, so it is very similar.
Josh is asking, what do opioids do to serotonin levels?
Well, the the problem with serotonin levels is the blood brain barrier separates the body's serotonin levels from the brain's serotonin levels. So we've had very few studies where we were able to test it immediately and directly, the brain levels, because those were actually only done during open brain surgery when patients volunteered to have little samples taken. We've done it on monkeys and dogs, things like that. And we see that it starts to exhaust the person. The amount of energy metabolism within the body during a seeking and then a high is huge. And it starts to exhaust the body in general, but the serotonin levels begin to go down. For all the therapists out there, this is interesting. Speaking of serotonin, a study came out last year concluding it was actually a meta-analysis of all the other studies ever done on serotonin levels and depression, finding that low serotonin is we have no evidence to connect low serotonin with depression. And so that basically, I've been telling patients the opposite for 15 years, and half of my practice was depression, anxiety, and bipolar. And so I had a lot of patients, probably 600 a month, among my providers and me that were treating that. So I was telling them that we need to bring up their serotonin for that reason. We do know that serotonin medications that bring up serotonin do help a person feel better, but it's not the cause in the first place. So it's like getting Tylenol for pain. It wasn't a lack of Tylenol that caused the pain, but it does help. And the same thing with giving SSRIs, but there isn't a direct connection. So that's kind of a disconnect between our theories we've had in the past. The one thing in deep dive studies with individuals, they were able to connect to almost all cases of depression, well over 90, was trauma. And not necessarily trauma, the big T traumas that everyone thinks about, rape and assault and death and car accidents, things like that. But childhood, adolescent, even young adult trauma of feeling overwhelmed and feeling helpless or things like that. And then it gets triggered by something in between 20 to 40 years old, something triggers that, and the person goes into depression. We don't know 90% of really what's going on there, but that's the connection we made recently. So there's a side note on serotonin. Um, other questions? I'll move on to the next slide and then we'll take more questions after that. So medically assisted treatment, MAT or MAT, is specifically buprenorphine treatment. The reason I focus on buprenorphine is because methadone is more difficult for patients to get. They have to go to a methadone clinic, although there are some laws that might be passed here right now that are going to allow addiction specialists to prescribe it out of their office as though it were a methadone clinic. But currently, methadone is harder to get a hold of. It's also more dangerous. It can cause heart arrhythmias and heart attacks. It also is more addictive and has a higher street value, that type of thing. So buprenorphine is favorable in all those ways because it's very safe. You can't overdose to a way that causes enough respiratory suppression to die. So you can't overdose on it. 2% of all overdoses in the nation have buprenorphine present in the blood supply, but they also have either other opioids like heroin, or they have high levels of alcohol or benzos. So we've come to the conclusion that we've had no overdoses where it was just buprenorphine in the system. So very safe in that aspect. So that's what I focus on, because the primary care doctors, this is kind of what this talk is based on, is the internal medicine doctors, the family medicine doctors, can safely prescribe it in their office. Now, in December 29th of 2022, President Biden's executive branch made an order that removed all previous certifications and trainings and restrictions that were placed upon family doctors and internal medicine doctors and things in order to prescribe buprenorphine. So that's all gone now. So all nurse practitioners in Utah, all family doctors can all prescribe buprenorphine. What we've seen in the last year is that almost zero people have taken heed of that call to help. And I'll talk a little bit about why in a minute here. But I've had my X license to prescribe buprenorphine since 2015. For my business, it's very nice that was taken away, those restrictions, but it still is a hard thing to integrate. So let's talk about this for a minute. When taken as directed, these medications are highly effective, enabling a large proportion of patients to achieve either abstinence or a substantial reduction in opioid use, also reducing the risk of overdose if a patient uses opioids. However, most people with opioid use disorder are not receiving medication treatment, a gap that urgently needs to be filled. Again, all these quotes come from articles. When you get the slides, you can click on those and go into those. I'm not going to reference each article. Our findings support the conclusion that adding buprenorphine to Medicaid-covered psychosocial substance use disorder treatment reduces patient attrition. That means patients who stop showing up at their programs, stop showing up at the doctor's office, things like that. And substance use disorder related emergency department visits or hospitalizations. But the buprenorphine treatment in office-based medical settings is even more effective in reducing these negative outcomes. Policymakers should consider ways to expand buprenorphine access in all settings, but particularly in office-based medical settings. So sobriety success statistics for different treatment modalities. Behavioral interventions alone have extremely poor outcomes, with more than 80% of patients returning to drug use. Now, the problem here is that every organization and every study used different, we haven't come upon a standardized diagnose or a definition of what we want to use as success. So we don't know if it's 1 month, 3 months, 6 months, 12 months, 3 years. And so you'll see organizations advertising that they have 60% success, and then you have to dig in, and often they don't even say what their sobriety success rates or definition is. But if you do get in there, it's definitely not 3 year, and that's what I feel is the best, is a 3 year sobriety success rate, because that truly is a good definition of long-term. So similarly, poor results are seen with medication-assisted detoxification. Extensive literature and systematic reviews show that maintenance treatment with either methadone or buprenorphine is associated with retention in treatment, reduction in illicit opioid use, decreased craving, and improved social functioning. So this isn't saying that behavioral interventions aren't important. It's not saying that medical detox isn't important. But go back to my example of being in the desert and being totally parched, and you've been out there for 3 days, and then you finally have a glass of cold water in front of you and you're told it's poison, you can't take it. That rationale doesn't last too long when you're that thirsty. What buprenorphine does, let's say you're standing next to the person trying to teach them good things, but they're just thinking about that water. What buprenorphine does is it is that cold alternative. It's Gatorade, and they get to drink that, and they're like, okay, my brain's calmed down now. I can focus on good things. I can participate with my therapy. I can go home and have good habits and start re-engaging at my job and with my family. And so it takes down their cravings. It definitely takes down their reward when they do use. And so over time, the brain stops associating the seeking and receiving of those drugs with so much relief. And that's what you want. You want to make it not a big deal when they take. They'll be like, oh, that wasn't that good. And I slept through work, and now my boss is mad at me, even though I've done so good for 90 days in a row. And then I used this weekend and I slept through work. Or I used this weekend and I got home and my wife was totally disappointed in me because I was sitting there sleeping while the baby was crying next to me and I was zonked out. We want to make the reward, the excitement lower. Now, when you preach to somebody abstinence of drugs, you say, you can do it, you can do it. And everybody that works at those programs are all success stories. Like 80% of the employees were success stories from those same types of programs. Like, we did it, you can do it. That person gets out, and the temptation builds and builds and builds, and then they use. And we know that the greater the taboo for any addiction, the greater the taboo for that person, like how bad it is for them to do it, it's actually the greater neural release when they finally do it. And that's one of the reasons we've seen that people that start to drink at 19 years old when it's illegal have tenfold addiction rate compared to people that drink 2 years later at 21. It's not just brain development, it's also taboo and illegal. And those things greatly heighten the neural excitement when you do something. So that buprenorphine helps the person benefit from the behavioral therapy. The buprenorphine helps the person benefit from all the things they're learning. They're able to get positive reinforcement at home. And then when they do use again, they're like, oh, that wasn't that great. That wasn't worth it. They do that. Let's say they reuse 7 times during their program. And you don't punish them for that. You just educate and help and make a relationship with them. They'll get to where it just isn't worth it at the end. And their brain finally makes that conversion back to an automatic response of, I want to talk to my friend on the phone. I want to go for a jog. I want to do my hobby instead of drugs when they feel stressed out. There were 7,624 opioid overdoses that occurred following the 81,519 total inpatient detoxification discharges, meaning that nearly 10% of all discharges from inpatient detoxification were followed by an opioid overdose at some point. I really should say in the next 12 months, with the majority of those being in the first 60 days. So the most dangerous thing you can do for overdosing is go to rehab and go to detox. The overdose danger in the following 12 months goes up 5 to 9-fold compared to people that don't go to rehab and don't do detox without having buprenorphine follow-up afterwards. So you're setting these people up for overdose. The greatest risk of opioid overdose occurred close to detoxification. In the transition between detoxification and post-detoxification, and among those who exited care, exiting following detoxification carried the greatest risk of opioid overdose. So that means they detoxed, went to a program for a while, and then quit the program halfway through. Say it was a 90-day program, they walked out at day 40 or something. Very high risks at those points. We conducted a prospective follow-up study of consecutive opioid-dependent patients admitted to a residential addiction treatment service for detoxification. We measured the rate of relapse following discharge and sought to identify factors that were associated with early relapse, i.e., a return to daily opiate use. Follow-up interviews were conducted with 109 patients, of whom 99 or 91% reported a relapse. So
We
the
have
importance. Oh, go ahead.
a
Yes,
question in the chat. Sorry to interrupt. But
yeah.
Jill's asking if we know the effects of buprenorphine on a fetus. She's asking because many of the kids that she works with have been drug exposed in the womb, and she understands the effects of methadone on the developing brain, and she's hoping that maybe buprenorphine is an alternative or something safer than methadone. Do you have any insight on that?
Yeah. So earlier in my career, I did a lot of obstetrics, um, OBGYN things. The American College of Obstetrics and Gynecology recommends buprenorphine now over methadone in all pregnant patients, um, due to lack of any evidence of developmental problems with the babies. In the modern day, we have a really hard time becoming super sure about the safety of medicines because we aren't allowed to do double-blinded placebo-controlled studies on pregnant women, in fact, since the 70s. And anybody that you're starting buprenorphine on in pregnancy has also had a shaky lead up to their pregnancy, probably. Um, they've had high risk behaviors of all different kinds, and so it's hard to know for sure. But buprenorphine seems safe, and it's definitely safer than methadone. And the withdrawal symptoms after delivery are about half than if the person was maintained on an opioid like methadone. Methadone's a synthetic opioid, but the withdrawal is about half. And so that is, we started using that about 15 years ago during pregnancy, but it didn't become the widespread accepted norm until recently. That's a great question. Yeah, so we do want to switch over. We want to tell those people they all have an option. And again, prescribing abstinence is great, abstinence from opioids, except that only 10% can actually follow through with that. That's not great, you know.
And
Any other questions?
Jenna is asking if you have any insight on dosing Suboxone with a patient who's been using fentanyl for time frame since last use.
Uh, so they've been it's been a while since they last used, or they're asking how long it should be since the last use before dosing the buprenorphine.
Let's
Um,
see. Yeah, go ahead. Go ahead.
so the however long acting the opioid is greatly affects our dosing and our timing of our buprenorphine. So we know, for example, that methadone super long acting. You often have to wait 72 hours of withdrawal symptoms before starting it to prevent precipitating a quick withdrawal, which precipitating a quick withdrawal is the number one way to make a person quit your treatment and never come back again. And so it ends up being a very negative experience for them. And so fentanyl is tricky. So let me back up there. Heroin, oxycodone, hydrocodone, morphine, fairly fast acting. Within 12 to 48 hours, we start the dosing of the buprenorphine. There's been a great lack of understanding about what dose a person should be on of buprenorphine. So most people are actually getting too much buprenorphine and having side effects because of that. And so we've learned a lot about customizing the dose to the patient, educating the patient a lot about withdrawal symptoms. So they look at their own skin to see if they have goosebumps. They look at their own pupils, and we give them a measuring tool to know if their pupils are the right size to be taking another dose instead of just panicking and taking extra doses, that type of thing. Fentanyl is the hardest of all. It's technically fast acting, but it's fast acting and it's also short acting in the hospital setting. Like if we give someone an injection of fentanyl to reset their broken bone in the emergency department, it's out of their system quickly and they can go home pretty quickly. After that, the effects are gone. But the effects, the withdrawal type effects, the physical symptoms of withdrawal in fentanyl after someone's used for a long time are the weirdest. And so we often use what's called the Bernese method or the microdosing method, nowadays. It's kind of it's been around for a while, but it's not really understood by most doctors. But we start with tiny doses very soon after their last use, and slowly creep those doses up. But we have to educate the patient a lot because they can adjust that dosing, and we will visit the patient in our practice in person or telehealth based on their needs every single day for the first 3 weeks, and we'll help them adjust those doses. Fentanyl's just tricky. And so what you're trying to do is not have the person have a bad experience or they'll quit treatment. And as we'll talk about, as you'll see here in the next few slides, staying involved in treatment long-term is the most important thing by far. Let me do this slide and then we'll see if there's more questions there. Compared to buprenorphine, discontinuation around the National Quality Forum benchmark, which is 6 to 9 months, longer treatment, at least 15 months, was associated with relative reduction in the risk of having all-cause inpatient, minus 52%, and emergency department, minus 26%, opioid-related hospital use, minus 28%, overdose events, minus 173%, and opioid prescriptions, minus 120%, and the rate of prescription opioid use, minus 124%. We argue that these clinical benefits provide a rationale for policies that increase access to longer-term buprenorphine treatment, including lengthening the standards for minimum treatment duration. For a great majority of patients with opioid use disorder, risk of relapse following treatment discontinuation is high, yet there is no consensus on the treatment duration necessary to achieve long-term recovery. In this study, among individuals retained in treatment for at least 6 months, high rates of adverse events occurred after treatment discontinuation, especially among patients with comorbid mental illness. Longer as compared with shorter retention in buprenorphine treatment, i.e. a minimum of 15 to 18 months, was associated with superior outcomes. There's, I think, 3 slides on the same topic. I'll finish all those and we'll do some more questions. Maintenance with medications for opioid use disorder, MAUD, is the gold standard treatment for opioid use disorder, AUD, and results in better outcomes than short-term regimens or tapers. The protective effect of MAUD is greatly diminished upon discontinuation. Multiple studies have found maintaining abstinence to be rare, while risk of overdose and other adverse events increase substantially, especially in the first 2 to 4 weeks following cessation. As a result, the National Quality Forum endorsed a minimum of 180 days of MAUD as a quality measure for AUD treatment continuity. If you remember the last slide, they were saying that's not long enough. They were saying those guidelines are not long enough. It needs to double. Despite these recommendations, barriers to access and retention in evidence-based treatment with MAUD remain an ongoing and critical challenge. First, only a minority of patients receive any treatment with MAUD. MAUD means buprenorphine or methadone, or naltrexone. Second, among those who do begin MAUD, sufficient retention to confer long-term protection is rare. Most patients who begin buprenorphine discontinue care within the first few weeks or months. So measuring success. Sobriety is an easy measure of success, but does not tell the full story. And if you look into the small print of all these different organizations and all the research studies, every single one has a different measure. But just as important are measures of quality of life and functioning. How is the patient functioning in their job, in their intimate relationships, in their maintenance of living situation, and in their parenting? Can a person have episodes of reuse of opioids during treatment and still achieve success? Absolutely yes. On average, participants reuse several times. On average, it's actually 7. That means between 0 and 14 times, but 7 was the middle. On average, participants reuse several times during the 18 to 24-month treatment programs, still achieving a high sobriety rate by the end of the treatment. And their sobriety rates are about 79%, which blows away the 5 to 10% 3-year sobriety after just a 30-day or 90-day treatment. If after 6 months of treatment, a person is feeling great and has achieved a couple months of sobriety, should they quit treatment? No. The data is consistent in showing that higher sobriety success rates are not achieved until after 18 months of consistent treatment. Several other studies have shown that discontinuing treatment should follow 6 months of total sobriety and high functioning at work, home, and relationships. So that means if you get to 18 months and you finish that treatment, you're doing good, but you haven't had the 6 months of stability, that you need to finish that program and then have 6 months of stability. That's the ideal time to taper off. So a proposed practice model. So I have directed the medical consultation team at Aspen Groves Behavioral Hospital, which was previously Provo Canyon Behavioral Hospital, for 13 years. I was also the attending physician for the detox unit in 2015 and 2016. And I just quit that because my wife uh, ended up having cancer at that point. So I had too much going on, but stopped at that point. I owned a large family practice in Orem, Utah, where 6 nurse practitioners and I treated 1,200 patients per month. I incorporated outpatient buprenorphine detox and maintenance treatment in my practice. My nurses, providers, and I found it to be very difficult to integrate the unique needs of buprenorphine treatment into our regular workflow. Patients beginning treatment needed many visits over their first few months. So you couldn't, if you're treating a bunch of pediatrics and prenatal care and diabetes and heart disease, and you're busy already, and the patient, normally a patient calls and you're like, yes, we have an appointment on Wednesday and one on Friday. What works for you? You have somebody come in for buprenorphine. They're like, oh, I need 20 appointments in a row. And you're like, how do you fit that into your practice? You have to block out sections of your practice. But then all of a sudden you get complaints from your diabetes patients saying, I used to love to come at 8 o'clock in the morning and now they're all blocked out or whatever. So it's difficult. And especially you get to rural America. And recently studies were done on how many providers are prescribing buprenorphine in the rural zip codes of America. 90% of all the zip codes had zero. So you try to take that rural doc who's already covering the ER, labor and delivery, the hospital, and doing their clinic and say, let's add in buprenorphine treatment. And these patients are going to be needy. They're going to need lots of visits. You're going to have to be available for them. You have to adjust their doses. And they're like, no, I just can't. Sorry. So the notes are different. The lab testing and supervision are different. It became clear that to achieve efficiency, at least half of my practice would need to consist of treating opioid addiction. And this wasn't possible because I already had 7,800 non-addiction patients. So this was actually a very hard decision and was a very difficult process for me. But in 2023 is actually when it happened. So in 2022, I made the decision to close my family practice and open a new practice dedicated to treating opioid use disorder. And it's called Resilience Health. It's actually just starting now. It's taken a year and a half to actually do this process. What do we do at Resilience Health? First, Resilience Health is an office-based primary care medical practice. We operate as though opioid use disorder is a chronic disease like diabetes. We integrate a thorough psychological evaluation from our associated psychologist to identify dual diagnosis such as depression, anxiety, PTSD, bipolar, etc. We then refer patients to the proper therapists and invite them to participate in our group therapy programs. Our program is a minimum of 2 years, during which time patients are seen 140 times. 80%, actually probably closer to 85% of these visits are telehealth. And that's just for convenience. The number one thing that makes a program successful is people don't drop out of it. When you have a 2-year program, you've got to make it easy. We mail order the meds to their mailbox. They can do virtual group therapy. Our appointments can be virtual because we need them to stay engaged for those 2 years. The problem is they're going to feel great at 6 months. They still have another year, 18 months before they even get to the stability in the brain part. And then we want 6 months of stability. And so we have to make it super easy for them so they won't drop out. Most people will shy away from treatment for years if their only option is inpatient 30 to 90-day rehab. And I think of myself, and if I was starting to have an opioid problem and I'm managing a medical practice and I'm busy at church and with my family, I'm like, I'm going to disappear for 90 days. No, it's not that bad yet. I can get over this. And you wait another 6 months, and it's 12 months, and 18 months, and 2 years, and then I get a DUI, and then I miss 3 days of work, and my boss says, "Hey, you didn't even call in for 3 days. You can't do that. You're gonna get fired." And then my wife's frustrated, wants to leave, and then I'm like, "Okay, I'll do the 90-day rehab now." Well, that's not a great time to do it. It would have been great to get treatment from a primary care level of treatment instead of this is ICU level. This is like hospital level. If 2 years before that, they could have found an outpatient type of treatment. So inpatient treatment is vital for all the patients who've lost a great deal of their functioning and organization in their life. And we will refer patients to inpatient rehabs as needed. Any questions?
Yeah, and you may
Dr.
have
Tomco.
already. Oh, go ahead, please. Go
I
ahead.
was just going to say, they said that they're wondering how do individuals juggle being in treatment, like a residential treatment, while maintaining their job that gives them the insurance to do that.
They don't. Well, legally, depending on how big of a company you work for, they fall under corporate laws right now that make it difficult for that corporation to not face lawsuits if they fire you while you're trying to get medical treatment. And so, but smaller, let's say all the small, like less than 20 person jobs, all the welders and well, it's my small medical practice and all those little hair salons and things, all you think of the thousands of businesses that are small enough that they don't fall under those laws, you're just going to be fired. They're going to find a reason to let you go, and they don't have to obey those big corporate laws. And so it's rough. And that's the problem is if you're waiting until you get your second DUI and your license was taken away, or you're waiting until you're fired from your job to actually go to rehab, that's why we need many more family doctors, not just the 20 to 40, but we need a way for people to get treated. In my practice, they won't miss well, they might want to miss 4 to 5 days of work because detoxing is not comfortable, but that's it. Take a little vacation. No one has to know. Nobody has to know. And that's the whole thing is if we can get patients at the primary care level, which is like diabetes, when your blood sugar is only moderately bad. Sorry, I'm looking over these pictures here. I realize I'm not looking at you guys. I'm looking at the faces over here, but um, that's when we want to catch a diabetic. We want to catch a heart failure patient when they can still jog, but they're a little bit short of breath, but they're still functioning close to 100% because we can keep them that way for their rest of their life. It's super disruptive to ever have to go to the hospital. And I love hospitals. I like working in them. And I also am glad they're there when my diabetic has a coma or my heart patient has a heart attack. I love my cardiologist compatriots who go in there and 30 minutes later open that person's heart up and now they're doing way better. They still need that follow-up care immediately afterwards. Every person needs a primary care addiction doctor if they have addiction. And many of them will need a hospital, but many won't. And that's what we're hoping for because it does ruin things. It's a mess. Especially, let's say you work at a bank and you used to be the person that would count the actual cash in the back, or you work in as a police officer, as a narcotics detective. They might not openly demote you, but you're going to be shifted. You're not going to be working those spots anymore. I mean, just sorry, they're not going to have you doing that after they know you had a drug problem. So there is a lot of negatives to going to detox. So I think most people are hiding it and trying not to get treatment. So the ideal patient for outpatient detox and long-term buprenorphine maintenance therapy is one who is still maintaining the full-time employment or is functioning as a parent. They're still maintaining their place of residence. They also have not burned their bridges with their intimate relationships, including spouse, children, and close friends. Ideally, their social circle is still made up of non-drug users. These people have a high likelihood of success. That's the other thing. If you read the actual populations that are in these studies, they're around the medical schools, which is usually inner city, and the medical schools can usually only recruit people who um, have low functioning generally. I mean, a lot of the studies are not the same type of people as your patients. The people who are still middle class, working, functioning, have a high level of success, much higher than the studies can show. Um, so they will do well in an outpatient setting without ever having to go inpatient. We can do the detox outpatient. The number one variable affecting successful sobriety is retention in a buprenorphine program for the complete brain effects to take place. We are 100% about retention. The patients commit to the 2-year program up front. We don't offer any different. We don't offer 6-month and 12-month because if you look at the success curves, it's not until 15 to 18 months that we even see that curve. We want to hit that and then do the 6 months beyond that to actually have the stability. We don't offer shorter programs. If people can't be sold on that science that we have, then we aren't going to participate with that. We communicate with the patients daily, and we support them in customized manner on their life traumas and needs, etc. I don't have time to go into all the technology of that, but it's really cool. We can interview them in our initial 2-hour psychologist interview and my 1-hour interview. We can dig out those traumas and the things that have triggered them. And usually those are based on the calendar. There's times of year that bring that up more with that person. And we have, with our technology, ability to start giving them customized messages during those times saying, come in for an extra visit. We give them unlimited visits. I say 140, they could have 300, but in reality, we're going to have a hard time even getting them to fulfill their 140. But If somebody's having a hard time at 2 years out, and we know it's when their son died or when they had a divorce or when something like that happened, we'll see them every day for a while during those trigger periods. So one of the most important influences on the success of our patients is their support people. Be it a spouse, a parent, a friend, having a support person and network dramatically improves the likelihood of success. This process is very hard on those support people. They've borne the brunt of the addict's bad behavior. And now, I should have said now, but now in recovery, the addict receives lots of positive attention while the support person is often left alone, unsupported. Even worse, the detoxification process usually makes the addict pretty grumpy and short-tempered for a long time. We offer online group therapy for the family members, and we send them motivational and educational messages by text multiple times per week. Please, for you guys, feel free to send me any of your patients that you feel might benefit from high-quality medical care, their opioid use problems, and feel free to call me. I'd love to talk to you about your patients or just to talk more about opioid issues. What questions are there? Let's see. It's 1 o'clock now. I have enough time, but if you want to, you guys make the decision there.
Yeah. Emmy says, what about someone who is clean from opiates but is now using THC? They are in a treatment program that allows THC. Is this the lesser of two evils?
Not really. So the problem with THC is that the proponents for the recreational use and medical use proponents pretty much were all recreational use mindset. If you look at the medical doses that actually cause the good benefits as far as anxiety, pain, nausea, all the different benefits we see, which are real, they're not placebo, they're real benefits, are the equivalent of like one puff off a joint, not the whole joint, definitely not 2 or 3 joints. So that's like taking, 20 ibuprofens or something. You're not getting, you're getting different effects at that point. You're getting intoxication. It might make you really relax, that kind of thing. So the lesser of two evils, if marijuana had not been considered a narcotic for all these years, medical schools would have been able to do double-blinded, placebo-controlled, prospective, randomized trials on all the different breakdown ingredients. And I guarantee you we'll have 30 pharmaceutical-grade medicines based off marijuana within the next decade. They really work. The problem is we don't have that ability to do those studies right now. It's still a narcotic federally, and that's where all the funding comes from, is federally. So all we have is the complete marijuana, and that's not necessarily bad, except you're getting stuff you don't need also. And also people's ideas of how much they should use is way higher than the medical dosing that actually gives us the medical effects. So medical dose marijuana is much less, like the gummies. That's much less than a joint. That's like half a puff, and it gives them a good effect. So I'm a proponent of the benefits. I've seen people get off their opioids and seen people get off their benzos and give them back to me their Xanax. No one does that. So it really does help. How we draw that line, it's hard to know. I don't think it's the lesser of two evils unless the person is still using it as a addictive behavior.
So there's another question kind of going along with that. It says, with THC being used to help treat addiction and other pain management, would Suboxone or THC be the preferred method, especially with the research being limited on both substances?
Yeah. So the research data is probably 100 times stronger with buprenorphine. So it has data going back to 1969. That's when it was discovered. It was FDA approved in 2002 for the treatment of addiction. So because it was approved, we have real studies. We have, that being said, they're no good compared to like kidney studies or heart studies or for heart disease and diabetic studies, that kind of thing. But they still are, the volume of evidence is way higher. As far as preventing overdoses, preventing relapsing in a long-term period, like 2 years, buprenorphine is way more effective than THC. That being said, I'm a proponent of researching THC because it helps in so many ways.
Perfect. Lisa says, oh wait, someone who's clean. Sorry, I got confused here. I don't know. It says, what's a good site to send their referrals to?
Well, if they're looking for um, um, information, well, I would say my website. And we put all the information that I told you guys today all into our website at resiliencehealth.co. And you guys may or may not know this, but during the pandemic, there were a lot of bad actors that got into the rehab industry to make a quick buck. And because of that, there was a crackdown um, on advertising um, for anybody treating buprenorphine and things like that. Um, but that delayed us of getting our marketing and website up by about 5 months. On the good side, it helped us make a pretty informative website. So it's resiliencehealth.co, but not .com. It's like Tomco. My last name Tomco is .co.
Perfect. I think that's all the questions I see. Joseph?
Yeah, no, that's good. I think Lisa's comment was just kind of piggybacking off of Emmy's, the one that we dealt with dealing with THC. Lisa's question was, or someone who is clean from opiates thanks to Suboxone, but is increasing in alcohol consumption. So I think she was looking for maybe a suggestion for someone maybe who was increasing their alcohol use,
Yeah.
maybe in that term.
So the medicine Vivitrol, long-acting Vivitrol, very effective at helping both opioid and alcohol. We don't prescribe that from our practice yet because it would add another layer of, I want to stay laser focused and hit this opioid epidemic while it's exploding. Alcohol has exploded 300 years ago. It's like major problem. It's probably worse overall and all the bad outcomes. But the more so Vivitrol is something I would seek out. Uh, it really does help that exact problem of substituting one thing for the other. It is a problem. It's a huge problem of having dual, like having alcohol and opioids. That's a big problem. It makes it probably 50% harder to treat.
Yeah, so anyone still on that's looking for the survey, I dropped the survey in the chat. So please go ahead and click that link. If you run into any issues, if you're at Intermountain, I know you may have an issue accessing a Google Doc, but please just email me and I'm happy to email the link to you at a different email address, or if you're on a different Wi-Fi, sometimes that helps. Whatever you can do to mitigate some of these firewall issues that some people might be having. But normally, if you're just on a regular internet, it's just a Google Doc. It has a few questions. The questions are pretty harmless, and we'd like to get feedback from you. Was there anyone else who had any other questions before we let Dr. Tomco go? It looks like that's it. Great. Well, thank you for your time, Doctor. This has been very informative. Again, for anyone who's looking for a replay of this class, we should have it up on our YouTube channel by the end of the week. I'm hoping to have that up. So I'm just going to drop the address to our YouTube in the chat really quick, because I know Bruce asked for it at the very beginning. I didn't get a chance to answer that, but that's our YouTube right there. So you can review this course and any of our other previous courses that we've also published as well. So take a look at those. I'll just, let everyone know you have to be present in order to get a CE certificate for the course. But sometimes people like to just, check previous courses and just for their own education. That's a great way to do that. Just subscribe to our YouTube channel. Check out those videos. They're very informative. Thank you again, Dr. Tomco, for your time. This has been awesome, an amazing class, and thank you everyone for showing up.
Yeah, thank you, Joseph.